All right. Hello, everybody. We're going to wait just a second as folks are joining the webinar. Happy to have you with us here today. Thank you so much. We'll get started here in just a second. All right, wonderful. Well, thank you everybody for joining us tonight for a walk through Family Heart HoFH research. We're thrilled to have you here tonight. My name is Allison Jameson. I'm going to get us started before we get into the meat of our presentation. We have a few little housekeeping items we'd like to share with you, and then we'll get into the good stuff. So first, just a quick medical advice disclaimer that this webinar is for your information. It is not intended to be a substitute for medical advice. So please consult your healthcare providers with any questions that you may have. We would like to invite everyone as well, as you are joining us, if we can show on our next slide, you can see that we have a chat box. And so if you'd like to go in there, please use that chat box to introduce yourself. If you want to select on the chat everyone, then that will allow everyone who's on to see your name and where you're from. If you do just hosts and panelists, it'll just come to us hosts and panelists, and we would love to see who all is joining us here tonight. So I invite you to introduce yourself. Another feature that we have is the Q&A function. You will see that at the bottom. This is a place where you could enter questions as we go through the presentation. I will be watching in that Q&A box. We'll remind you of this later in the presentation as well, but as we're going through the information and the data, if you have questions, feel free to put them in there, and then we will address questions to our speakers tonight at the end of the presentation of our slides. We would like to also thank our partners for HoFH Community in Action Program, Regeneron and Amrit, as well as our Family Heart partners. And we are very grateful to acknowledge the support of Regeneron for the Cascade FH Registry program for the upcoming year. This registry plays a big part in what we're going to discuss tonight. So thank you to them and to all of our sponsors. So we are ready to get into our presentation tonight. So we're going to do an introduction of your hosts tonight, including myself and Dr. Mary McGowan. Dr. McGowan, I'd ask you if you'd like to introduce yourself quickly, and then I'll introduce myself.
Sure. Thanks, Allison. I'm Mary McGowan. I'm the Chief Medical Officer of the Family Heart Foundation, and I'm a researcher at Dartmouth Medical Center. And I am one of the authors of the paper, and Allison is as well. So I'm glad to be here with my co-author.
Yes, thank you so much. Yes, so as Dr. McGowan said, I helped to author this paper as well, which, I'm coming into this as a board member of the Family Heart Foundation, but also as a patient who lives with HoFH myself. So a very personal endeavor for me as well, and I was quite honored to be asked to participate in this paper, which was a long time coming, but had the opportunity to review drafts and to really represent, I think, the patient voice that resonates with my experience. I think that is something that would be of interest to patients. That's something that I could take to my doctor to help get my own treatment to where it needs to be and things like that. So I took that responsibility very seriously. And I think one of the amazing things about this paper that Dr. McGowan will discuss is, when you're a member of a rare disease community like HoFH, you can sometimes feel very alone, and you are one voice in a sea of many, and it's hard to be heard. And I think one of the powerful parts of this paper is how the registry brings together the voices of the HoFH community across the United States and elevates and amplifies that voice in a way that I think is really impactful. So I'm really excited for Dr. McGowan to walk you all through this paper, Contemporary Homozygous Familial Hypercholesterolemia in the United States. And I'm going to pass it over to her. We're going to walk through these slides, and then we'll have an opportunity again at the end to review any questions that you have. So feel free to use that Q&A feature. All right, Dr. McGowan.
Thanks so much, Allison. So I am really pleased to talk to you tonight about this paper. As Allison already told you, it's Contemporary Homozygous Familial Hypercholesterolemia in the United States, Insights from the Cascade FH Registry. So that's a mouthful, but as Allison said, the Cascade FH Registry has really allowed us at the Family Heart Foundation to watch the progress and care of people with both homozygous and heterozygous familial hypercholesterolemia. This paper happened to be published in the Journal of the American Heart Association. It's a very prestigious journal. And one of the things that happens when you publish a paper is that if you have the opportunity to pay to get global access for people. So in general, most individuals or groups don't pay extra money to the Journal of the American Heart Association after they've gotten their paper accepted. But we at the Family Heart Foundation decided to pay, and I think it was about $1,500 in order for anybody that clicks on this paper to be able to download it and to be able to download it without cost. In general, it costs about $35 if you want to download a paper. And we said, we want this to be available for everybody, whether you're a person with familial hypercholesterolemia, homozygous familial hypercholesterolemia, you're a researcher, or just a person with interest. We did that just as we fund the Cascade FH registry. We're very grateful to Regeneron for funding us for the last year, but for many years, the Cascade FH registry has been funded by the Family Heart Foundation by your donations. So we're grateful for those. So we really decided when we were doing this paper to think about a way that we could not only look at what happened in our registry, but also look at what might be happening in the real world. So we looked at two populations, not just the registry. So what we did was we looked at our two family heart databases. And as you know, and some of you may be participants in the registry, we have this Cascade FH registry. I know Mary Card, one of my colleagues, is on the call tonight on the webinar, and Mary manages all the day-to-day work with the registry. And the registry is a registry to longitudinally follow people with both heterozygous FH and homozygous FH. Because heterozygous FH is much more common, 1 in 250 people versus 1 in about 300,000 people, the registry, which is now very close to 7,000 individuals, which was started in 2013, has a lot more heterozygous patients than it does homozygous patients. And what we did in terms of the Cascade FH registry, we decided to cut the data to what we were looking at for our paper was the registry from inception in 2013 to April 2020. And that was a point where we paused the registry for a short while due to the height of the COVID pandemic. So at that data cut point, we had 51 adults and 16 children. And we chose to analyze the adults and children separately, and you'll see why. And of our 40 Cascade registry sites, 20 provided patients with homozygous FH, so provided the information of patients with homozygous FH. And that's what will be the focus of this discussion tonight. We also have a family heart database that the Family Heart Foundation has worked at and purchased data since 2012. This too is a big endeavor, a big cost, but we're very glad to do it because we want to know what's going on in the real world. This database includes 324 million Americans, but what we're going to look at here is the 81 million Americans who had sufficient data in this database, diagnostic codes, procedure codes, prescription data, because we wanted to know what meds people were on, and importantly, laboratory data. We needed to be able to figure out, is it likely that an individual in the database has homozygous FH? And what we did, out of 81 million Americans, there were 277 individuals who really mirrored the individuals from the Cascade FH registry with genetically confirmed homozygous FH. So these were sort of like clones of the people in the registry. And these 277 individuals out of 81 million Americans, that means that it's one person out of every 340,000. So that's roughly comparable to what we would expect to see. And we wanted to know what was happening with people in the real world. What was their kind of care? So for the bulk of this conversation, we're going to talk about the registry, but we will talk about what we see in the real world. Just to set the stage, as you know, there are two forms of FH. Heterozygous FH, where you've inherited a single gene for familial hypercholesterolemia, and the much less common homozygous FH. Just going to focus on homozygous here, but you can see you've inherited a gene from each parent. So if somebody has homozygous FH, look at their parents. They both have heterozygous FH. Typically, LDL will be above 400 milligrams per deciliter. And as you'll see, unfortunately, cardiovascular disease can occur in childhood in homozygous FH. We've updated this slide as new medications have really caused great hope for the homozygous FH population. We used to say most respond poorly to medications, and now we can say most respond well to new medications. And when we think about those medications, there are two meds that are specific for homozygous FH, lomidopide and even uncumab. And those medications give a lot of hope to individuals with homozygous FH. And again, it's a rare disease, as Allison pointed out as well. This looks at the sites that we have in our registry. So you can see we have sites all across the country. There are 40 sites, but specifically 20 sites contributed to this particular paper. And what we see here on the under the adults, we have 51 adults and 16 children, so a total of 67. I would like to point out that now that it's 2023, we have 92 patients with homozygous FH in the registry now. But one of the things that we found very important to look at, and we'll get into this in a minute, we noted that those individuals that entered the registry as adults, their untreated LDL, their median untreated LDL was 533, very, very high. But look at the children who entered the registry with HoFH, their median LDL, that's the 50th percentile, was 776. So more than 200 milligrams per deciliter higher than the adults. If we look at atherosclerotic vascular disease at enrollment, at the time they entered the registry, 78% of adults and 44% of children. And at the time of their last visit, remember we did the data cut in April of 2020, adults had had a dramatic reduction in LDL from their untreated baseline, 72%, as had the children, 61%. But because they're starting from such high untreated baselines, only 32% of adults got their LDL to goal. And what is goal? Goal for individuals with cardiovascular disease, whether they're adults or children, would be an LDL less than 70. And for children, if they don't have atherosclerotic vascular disease yet, the LDL goal would be less than 130. Lower would be better. And for adults without cardiovascular disease, an LDL less than 100. And 25% of children achieve their goal. So despite aggressive lipid-lowering therapy in specialty clinics, not everybody was able to achieve their lipid goals. And I think this is a very important slide, which I'd like to take a little time to review with you. So this is a figure from the paper, and it's the age of diagnosis, children versus adults. And what you'll see is on the x-axis, this is the age of diagnosis, and on the y-axis is the LDL level at diagnosis, so before any treatment. The children are depicted as red triangles and the adults as black circles. And what I would point out here, if I can get my arrow over here, is the children are all clustered here. The children all have very high LDLs and they're diagnosed in childhood just by definition. But you can see very, very high LDL levels. Now, there's some adults, now these adults entered the registry as adults, but they could have been diagnosed as children. And you'll see that the adults who were diagnosed as children also had very high LDLs. So other people get diagnosed much later. They get diagnosed later in adulthood. And so these individuals are lucky in some ways because they're diagnosed early. But we think that only the very highest LDL children and those who were who entered as adults but were children with diagnosis, only the people who are at the head of the spear, the people with the highest LDLs, get diagnosed early. That means that these individuals who may have somewhat lower LDL levels, they sort of slip through the cracks and they are not being diagnosed until something happens. For example, a person who had genetically confirmed homozygous FH in this study was not diagnosed until 37 years of age at the time of a heart attack. There was somebody in this registry, one person in the registry wasn't diagnosed. This was a clinically diagnosed person, but not diagnosed until they were 65, also with a cardiovascular event. So these people don't get treatment the way they should early in life. And so they end up being diagnosed when they have an event. So we've already talked a little bit about the fact that 78% of adults, 44% of children had cardiovascular disease at the time of entry or prior to entry into the registry. But I'd like to draw your attention here. So if we look at the adults, 40 out of 51 already had cardiac disease when they enrolled in the registry. The median age of onset of cardiovascular disease in these individuals was 30, whereas children, 44%, 7 of 16, had cardiovascular disease at the time that they were enrolled into the registry. Their median age of onset was 9. That is 2 decades earlier than the adults. Bypass surgery was very prominent in adults, 21 of 51, so 41%. The average or the median age of the bypass surgery was 28 in adults. 2 of the 16 children in the registry had already had bypass. That's 12%. What was the age of onset? The median age of onset was 10. So again, almost 2 decades earlier. Liver transplant. For those of you who don't know this, liver transplantation can be curative for people with HoFH because you give somebody a liver with healthy LDL receptors, but it comes with a lot of issues. Liver transplants, you have to take immunosuppressives for the rest of your life, and it is a very big procedure. There were 2 of 51 people who entered the registry as adults, or 4%, who had a liver transplant. But each person in this registry that had a liver transplant was 18 or under. So that of the 2 people, the median age was 17. That means one was less than 17, one was older, 16 and 18 in this registry. So really all children, they just got enrolled as adults. 3 of 16 of the children enrolled as children, or 19%, had liver transplants. That's the age of onset there was 6. So at enrollment, 41% of adults and 69% of children were taking less than or equal to 2 lipid-lowering therapies. 39% of adults and 31% of children were receiving apheresis. And we know that apheresis is really important as a modality of care for people with HoFH. At the most recent follow-up, meaning at the time of our data cut, April of 2020, 82% of adults and 87% of children were taking 3 or more lipid-lowering therapies. Many people were taking 4 or 5 lipid-lowering therapies, and those are the people who get closer to goal. 41% of adults, 75% of children were receiving apheresis. And so what we can glean is the improvement in adults in terms of their LDL levels from the time of enrollment until the data cut was the addition of PCSK9 inhibitors. And for children, it was the increased use of apheresis. And although the data collection ended in April of 2020, and evinacumab, you may know this as Evkeeza, was not approved until February of 2021, we did have 6 adults. So we were able to get a picture of what evinacumab might do. We did have 6 adults on this agent. They were individuals who were on an open label clinical trial. That means the open label means you knew what they were taking. And these adults experienced a 50% reduction in LDL with the addition of evinacumab. It's now approved. It's recently been approved for individuals with HoFH 5 years and older. When it first got approved, it was 12 years and older. So we know, based on what I just showed you, that you can have children having bypass surgery at 6 years old. You want to be able to initiate this therapy early. We know that people who have homozygous familial hypercholesterolemia get into trouble with early cardiovascular disease. I've shown you that. Probably some of you have experienced this. And even in the registry, as people were being treated aggressively, as we followed these people longitudinally, some people had events. So we have follow-up data for a subgroup of 39 adults and 8 children with a median follow-up of 3.8 years. And during that follow-up, 5 individuals, so this is 5 out of 67, experienced 7 significant cardiac events. Luckily, no children experienced an event during the follow-up. 1 aortic valve replacement, 4 heart attacks at ages 46, 53, 58, and 65. 1 person had a stent, and unfortunately, 1 person experienced cardiac death at age 51. So I want to get back to talking about this profound difference between children and adults in their median untreated LDL. So the profound difference between children and adults indicates there's a potential survival bias. And what does that mean? It means, sadly, that some individuals don't make it to adulthood, so that people that had really elevated LDL levels as children, if they passed away in childhood or young adulthood, we would not be, the age, the LDL level at diagnosis would appear that to be lower in adults. But I think that it's most important that we recognize that this really suggests that only individuals with the most severely elevated LDL are diagnosed in childhood. And I showed you in that previous slide that adults with the highest untreated LDL levels were also diagnosed in childhood. Here we get back to the Family Heart Database. This is our second data set. And this is where we got to see what is it like in the real world. And this was the 81 million Americans that we had enough diagnostic codes, procedure codes, laboratory data. And so we looked at these individuals and we asked how many people looked like they have the same characteristics. And it was 277 individuals. 84% of these people were under the age of 50. They were young, a young population. The median LDL level in this group was 444 milligrams per deciliter, and only 26% of these people had an FH diagnosis, and a full 20% already had cardiovascular disease. So we wanted to look at lipid-lowering therapies for these individuals. And so it was a shock to find out that a full 40% of individuals with LDL levels this high were on nothing, no lipid-lowering therapy. 11% were on low or moderate dose statin, 19% on high intensity statins. The combination of statins and Zetia, there were about 12%, adding a PCSK9 inhibitor in the real world, only about 14%, and lomidopide, which is a drug specific to people with HoFH, only 5% of people were taking that. So in the real world, HoFH appears to be both underdiagnosed and undertreated. So what is our clinical perspective? And this we published in the paper. Again, I sound like a broken record, but only individuals with the most severe phenotypes, the highest LDL levels, are diagnosed in childhood. And this results in a missed opportunity to prevent early atherosclerosis in everyone with HoFH, with timely initiation of aggressive lipid-lowering therapies. Within the Cascade FH registry, even with aggressive lipid-lowering therapy at specialty centers, only 32% of adults and 25% of children reach their LDL goal. This was 2020. A lot has happened since 2020 in the HoFH world, and we are very hopeful, and we're looking forward to doing another data cut at a later time to see what has changed with the addition of, for example, evinacumab to the clinical armamentarium. In the real world, the situation is more dire. Of the 277 individuals with likely HoFH, only 26% were diagnosed, 19% were on high-intensity statins, 18% you saw were on more advanced lipid-lowering therapies, but a full 40% no therapy whatsoever. Here's, I think, something very important. Universal lipid screening of all children is critical to ensure a timely diagnosis and treatment of all patients with HoFH. But many children are missed, and they are now adults. So it's never too late. We should screen. So screening children, screening adults, and always keeping in mind when you see somebody with a very high LDL that this could be HoFH. So such screening, universal screening of children, would allow the diagnosis of parents with undiagnosed HeFH. Because remember, you don't just have a child with HoFH. You have a child with HoFH because you have two parents with HeFH. And, if more individuals, more clinicians followed the American Academy of Pediatrics guidelines and the NIH guidelines that say, in a family where there's early cardiac disease or a history of FH, screen a child at age 2. But suppose that gets missed. These guidelines also say universal screening of all children between the ages of 9 and 11. And that's to look for people with FH. And one of the things that we know is that one of the things that seems to prevent clinicians from doing this, from screening universally, is a group called the U.S. Preventive Service Task Force, whose mandate it is to promote health and preserve life. And what they say is, and they've had multiple times when they've reviewed the evidence for screening, universal screening for in children and adolescents. And each time they've had the opportunity, they've said there's insufficient evidence to recommend universal pediatric and adolescent lipid disorder screening. And this gives clinicians a sort of an out saying, I'm not going to screen. And what this stance, or what their recommendation is a recommendation in which they say HoFH is out of scope of this set of recommendations. And so what we believe at the Family Heart Foundation is that the individuals at the U.S. Preventive Service Task Force are doing a disservice to individuals with HoFH. They seem to think that everybody with HoFH is diagnosed. And in our paper, we really stress that this is not the case. I'm just going to go forward a slide, and then I'll come back. These are physical findings associated with familial hypercholesterolemia. You can see here is a xanthelasma. It's a cholesterol deposit. Here are some more around the eyes. Here is something called corneal arcus. It's a rim of white around the colored part of the eye. That's a cholesterol deposit. And these are cholesterol deposits in the tendons of a person's hand. these are often overlooked. Now, these are more general for HeFH and HoFH. These are tuberous xanthomas and tendon xanthomas that can be seen in HoFH. But they are not always present. And that's why the US Preventive Service Task Force is wrong in saying that it's out of scope. Somebody doesn't walk into their doctor's office with a sign around their neck that says, I have HoFH. It just doesn't happen. And this is Jessica, who I think is on the line today. She said, he said he had children in his practice with high cholesterol, but never that high. And she said, I went for 7 years thinking that I had a perfectly healthy child. Who would think that the bumps on the knees would lead to this? This is her daughter who had bumps on her knees that were thought to be something called molluscum contagiosum, which is a virus that kids get. So even when there are physical findings, a lot of times they're overlooked or they're misdiagnosed. We have a family in Boston that's part of our support group for HoFH. Their child was diagnosed, quote unquote, with molluscum contagiosum for 2 years, delaying the diagnosis of HoFH. And by the time he got the diagnosis, he had an occluded right coronary artery. So it should not be out of scope for the US Preventive Service Task Force. And we have spent a lot of energy at the Family Heart Foundation, and lots of family members signed off on our letter to the US Preventive Service Task Force. We did recently get a communication from them saying they are looking at our paper, they're looking at our letter that was signed not just by us and families, but signed by the American College of Cardiology, the American Heart Association, the National Lipid Association, all saying that the US Preventive Service Task Force is doing a disservice to people with HoFH. Patients with HoFH require urgent treatment. It's an emergency. Multiple lipid-lowering agents to achieve their LDL goal. And the diagnosis of HoFH will allow access to newer HO-specific therapies. So getting that diagnosis in the chart allows people to be treated with lomidopide and even uncumab, drugs that are reserved for HoFH patients. We think that it's all of our responsibilities to increase the awareness of HeFH and HoFH, and this is critical. So it allows the diagnosis of people and gets people referred to specialty clinics in a timely fashion. We've already looked at these. In 2018, really our commitment goes back to 2013 when or 2011 when we first established the Family Heart Foundation. But in 2018, the Family Heart Foundation partnered with the World Heart Federation and convened individuals with FH, advocacy leaders, policymakers, expert clinicians, and scientists from 40 countries. And these were low, middle, and high income countries to draft a global call to action. We had 9 tenets, 9 recommendations, and one of them was for severe HeFH and homozygous FH to create as a special case separate guidelines for these individuals, defined as either a presence of an LDL greater than 400 or a pathogenic variant in one of the genes associated with FH, and any FH related or any of the FH related alleles, as well as a family history of cardiovascular disease. This was a list of the countries participating. This is all individuals at our global summit. You can see Allison in there. So there have been other registries that have been published. In 2022, just prior to the Family Heart Foundation HoFH paper, data was published from the International HoFH Registry, and this is data from 38 countries. And just after we published our paper, the Canadian HoFH Registry was published. And I will say that as I read the Canadian findings, they were very similar to our own in terms of therapies and diagnosis and treatment. And the data from the international community was really quite disturbing, but sadly not surprising. People with HoFH from poorer countries had less access to lipid-lowering medications, and as a result, their lipids were less well controlled. And their first cardiac event occurred a whole decade, 10 years earlier than people with HoFH who live in wealthier countries. And really, it's nobody's fault if they have HoFH. You didn't ask to have HoFH, and therapy treatment should be a given, and it should be a priority of governments. It should be a priority of our system, of our policymakers. So what are some key takeaways? There may be people that are on this call today that they themselves have HoFH, or they're thinking that maybe they do because their LDL is very high, or they care for somebody with HoFH, or you work in research, or you work for a company that makes some of these really important HoFH medications. But it's important to know to advocate for yourself and your family members. Very high LDL is a known risk factor for cardiovascular disease, but it often goes untreated or undertreated. Even people who have the highest levels, as we saw in the real world data, we have people with LDL levels far over 400 who are on no therapies. The HoFH diagnosis is often missed. So contrary to what the US Preventive Service Task Force thinks, people with HoFH often do not know they have it. They get diagnosed at the time of a cardiac event. The clinical diagnosis of HoFH can be made based on an LDL over 400 and family history. You can do genetic testing, that's for sure, as well. Cholesterol screening for children and adults, especially adults who were not screened as children, is key to finding people with heterozygous and homozygous FH. If you have a cholesterol level, an LDL cholesterol over 400, you should consider that needs to be urgently cared for. And there are treatments available today that can help people with HoFH get to goal. If your cholesterol level is very high, you should feel free to contact the Family Heart Foundation, our Care Navigation Center for help. We have a care navigator standing by, available during business hours, and you can get in touch with the care navigator by email, by calling, and we will be back in touch with you as soon as we can to help you through any hurdles that you're going through. I'm going to stop here, and I'm going to stop sharing for a moment. And Allison and I will just have a little conversation, and I know that there may be some questions in the Q&A. I haven't been looking, but I'm sure Allison has. So I just want to start out with asking Allison, knowing your own situation, did it surprise you that some adults with HoFH, even in our registry, weren't diagnosed until their late 30s, 40s, or 50s, often at the time of a cardiac event, such as a heart attack? And, we wonder about your own experience there.
Yeah, it was absolutely not surprising to me at all, because this is pretty much the story of my life. Knowing that I had very high cholesterol from a young age, but not diagnosed as HoFH until I was 35. And that was after a heart attack, after 2 bypasses, and after an aortic valve replacement. So as in hindsight, I look back and it seems really, I think I would be the patient that doctors are assuming, of course, she was diagnosed. She had very high cholesterol levels. She had the xanthomas. She had the bicuspid aortic valve and aortic stenosis, and yet I wasn't. So it was not surprising to me at all. And I felt very much that it mirrored my own experience. So in that way, it was okay, I see myself in this. And then at the same time, just really devastating to know that still hasn't changed in my lifetime, that is still happening today.
Right. I couldn't agree more. So I guess maybe this question, did you find it unexpected that at the time of enrollment, both children and adults were grossly undertreated?
I think even the level of it was surprising. I wasn't surprised that a lot of people were undertreated, but I mean, the 40% absolutely untreated blows me away and is terrifying. I know even through my own experience, even knowing that I had very high LDL levels, I lived my whole life not at goal, and taking single medication treatments, one statin, one of this, and not ever really getting anywhere close to range. We're still talking 400 or 500 even on medication. So I expected it, I think, but not to the level that we saw it. And just the undertreatment. And I think, again, as you noted, that just those that are completely untreated is really stunning.
It really is. And so, Allison, we worked on this paper for over 2 years together. You edited numerous drafts, you provided insights, you reviewed the data. And I was going to ask, it sounds like you were frustrated a little bit in terms of the real world data. But what was your experience working on the paper? How did you enjoy it?
I think it was really an amazing opportunity to be able to, validate, I think, in real time, as of course, many of the authors, and I should have mentioned at the beginning, there were 33 authors on this paper. It was obviously not just the two of us.
Oh, come on.
But to validate for those that like, yes, this was my experience, because I think sometimes you look at it and say, well, that can't be right. That cannot be what is happening to this population of people. And to say, yeah, it is, that is what happened to me. Like, that's very similar to what I saw, but to then hear stories of other patients that had been treated by individuals who are contributing to this paper. And that really is, I feel very confident that this is an accurate reflection of what is going on in the world. And to see, I think, the joint frustration gives me hope that, okay, like, other people are going to read this and get equally frustrated. And other people are going to react. I think I very much heard the passion in your voice in speaking about screening. I hope that is what this paper inspires in others, is a passion to, we have to change this. This is absolutely unacceptable. So while it is frustrating and angering, at the same time, it was like, okay, this is going to do something. This is going to have an impact. And I think that part of it is the part that gives hope.
That's great. And how about your own experience with these newer agents? I know that on another webinar you shared your current LDL. Are you hopeful that people with HoFH will get treated more aggressively?
Yeah, I think, when I reflect back on the time that I've been engaged with the Family Heart Foundation, and I think back on my life, like at the very beginning of this journey, and I've been engaged now for close to 10 years, there weren't a lot of options, but now there are. And I said the other day, and I still think it, I feel like we're in like this golden age of lipid research. And, I mentioned I had a heart attack at 34, I had bypass at 34, I had bypass at 28. So hitting that median exactly from the paper. But today my LDL is 52. I mean, it's unbelievable. Right. And it's a combination of therapies, right? And everybody's going to respond different. And there may be some that don't work for some, but others do. And so just so important to get multiple treatments going as early as possible. So I share your passion for the early screening and early treatment of children, and hope that we can avoid my experience for those who are coming after us, that can be diagnosed earlier and can be treated earlier. And, it is possible. Like it's an absolute miracle every time I get my lab work right now.
That is so great. And you started out close to 800, right?
Yes. So
that's
it's
amazing.
Come a long way down. So
that's fantastic.
Yeah.
So I am always marvel at you, Allison. I just think you are the greatest. And you have a high-powered job, a full-time job at Duke. You have 2 kids, a husband, and yet you find time to be on our board of directors, the Family Heart Foundation board of directors. You're a passionate advocate. You're here tonight, spending your evening with us. You've traveled to Washington, D.C. to advocate for research funding for FH. You roll up your sleeves. You're on every committee we ask you to be on. And how would you encourage others to get involved? Or some people, I guess, are maybe are not as willing to, maybe are more on the sidelines. But what drives you to be so involved with the Family Heart Foundation?
Yeah, I think that for so long in my life, I didn't know anyone else who had this. And the only people that I knew that knew anything about it were people that I was related to. And so to have found the Family Heart Foundation and found a community of people with similar lived experiences, similar goals and frustrations, for me, it was like, this is now time. I'm going to be a part of this. I'm going to add my voice to this organization, and I'm going to do everything I can to like raise this flag. But what I think is great about the Family Heart Foundation is you can do that. And I think it's awesome. Obviously, it's where I'm choosing to spend a lot of my time. My family's involved, but it's also here for folks who are looking for support, who are looking for a place to hear from others who have been through this, to share their experiences, to be heard, to meet someone they're not related to that's dealing with the same thing. So there's a full spectrum of opportunity here. And it's really up to the individual of, do I want to serve on a committee? Do I want to be, you mentioned the patient advocates. Do I want to be a part of that program and raise awareness in my home community? Or am I looking for, I don't know where to go next. I just need someone to point the way. Can they tell me a doctor? And you mentioned the Care Navigation Center. If I just want to be heard, there's a Facebook group, there are discussion pages. You can connect individually with another person who's living with this. We have blog posts, we have webinars. There's so many resources out there that I think you can really choose the level of engagement that is comfortable for you. But I think the important thing is, no matter where you fall on that spectrum of, I want to do this all the time, or I just want to check in and make sure that I feel okay about this, there are resources and opportunities for you in that, and that you are not alone. There is a community here to support and provide resource.
That's great. That's wonderful. Very well said. So do we have some questions? I'm looking at the Q&A here.
Yeah, and I think that we have a question as well, specifically about liver transplantation. So the question is, patients who respond to PCSK9 therapy have issues with LDL receptors in their liver. This person thought the issue was the protein in the blood that disrupted LDL liver clearance. So I guess sort of a question about the mechanism.
Let me see what so there are, let's just see, is this in the chat?
It's in the chat, yes.
I think I need to look at it. Let's just see if I can. I've got to get rid of this. So is the question, does a liver transplant work for somebody who has a different disorder? Is okay.
So yeah,
so
can you see?
Yeah, now I can.
Okay. Okay.
So interestingly, there, people who have LDL receptor defects as their cause of HoFH, they can respond beautifully to PCSK9 inhibitors. There are some people that don't respond necessarily beautifully to PCSK9 inhibitors. If somebody's disorder is an LDL receptor defect, and that's 95-96% of people with HoFH, and they get a liver transplant, they get new effective LDL receptors. So they should be able to now remove LDL cholesterol very effectively. So most people with HoFH will respond to a liver transplant. We're very hopeful that liver transplants won't be necessary anymore. We had those individuals in the registry that got liver transplants. I should mention that there was primarily, almost all of them were at one site, and that was at Columbia, where the Rogerson Center, Lisa Hudgens site, and they have a very special expertise in it. People did very well. They were able to have near normal lipid levels, and they did very well. We, in fact, took the individuals who had liver transplants out of the analysis for the LDL levels, because we didn't think it was fair, because their LDL levels were normal and they were not on statins for some of them. So a liver transplant can be curative, but it is also a big procedure, and you need to be at a center where they do it regularly.
Mm-hmm. Is there a case where a liver transplant would not be curative?
It's a good question. If somebody had, for example, an APOB mutation, APOB, if you have a mutation on APOB, it means your LDL's APOB is not being recognized by, it needs to be recognized by the LDL receptors on the surface of the liver. So I don't know it for sure, but I think that if APOB is your mutation, you might not respond to a liver transplant, but don't hold me to it. I don't know that literature as well.
Okay, so this is a question that I think is a great one for folks. What if you are trying to get a diagnosis, is there a specific test? Like, what should someone consider testing wise to confirm a diagnosis?
Yeah, that's a really good question. And so I think that if you have an LDL untreated greater than 400, and you have parents with either LDL levels untreated that are the LDL is greater than 190 untreated, so that would be considered potentially heterozygous FH. So if you have two parents that are similarly impacted with elevated LDL levels, then we would say your LDL greater than 400 likely represents HoFH. Alternatively, if someone has an LDL greater than 400 and they have physical findings, and it's typically said before the age of 10, so those tendon xanthomas or corneal arcus, that would be another way to say yes. And if somebody has an LDL greater than 400 and both parents had early cardiovascular disease, I think all of those would lend the clinical diagnosis of HoFH.
Would a patient ever get back a lab result with high levels that says diagnosis FH, that wouldn't come from a lab, that would need to come from a physician?
Well, sometimes some labs will say sometimes it's a particular hospital lab, they can make their own choice of what they do. But sometimes a hospital lab, if somebody has an LDL greater than 190, they'll say consider HeFH. If someone has it greater than 400, they might say consider HoFH. So there is sometimes flagging from labs.
Okay. So what would someone do if they meet some of this criteria that we've talked about? Say their LDL is over 400 and they don't feel like their current physician is very knowledgeable. How should they approach their care provider?
Yeah, I think that you need to be assertive. And sometimes that's not somebody's natural inclination. Sometimes people's inclination is to just trust the doctor and say, oh, I'll do whatever, but it's your life. And you don't want to have a cardiac event. And so what I would suggest is calling the Care Navigation Center, contacting the Care Navigation Center. One of our greatest tools that's asked for frequently is our specialist map. And so we can find a specialist who's close in proximity to you. A great example was Jessica, whose picture you saw with her husband and little girl. And Jessica called Kat Davis Ahmed, and or they met on Facebook, and then Kat said, "Can I contact you?" And we got Jessica in touch in short order with Ann Goldberg, one of our PIs for the registry, and a really great physician. And so I think that we have relationships with HoFH and HeFH specialists across the country, and we can always pick up the phone and get somebody in quickly, because HoFH, as we said, it's urgent.
I think we have maybe 2 or 3 other questions, and then we can wrap up. You had mentioned that evinacumab even came out at the sort of tail end of this timeline of this paper. Is that drug currently only approved for HoFH, or is it also approved for HeFH?
No, it is only approved for HoFH. So the FDA approved it specifically for HoFH, but initially when it came out, it was approved for 12 and up. But I think that it's very clear that that's too late for children with HoFH who can have cardiac events, at 6, even younger. And so we're very pleased that the FDA has recently said, okay, it's approved for 5 and up. So that's great, but it is not approved for HeFH.
Okay. And I think this is kind of a 2-part question. We've talked about the urgency of treatment, even in very young children. And I think sometimes there is a hesitancy to medicate children. So what is an appropriate age to start children, and what are the options for very young children?
Yeah, so for the current recommendation for a child diagnosed with HoFH is start them as soon as the diagnosis occurs. And, being a parent of 3 kids, I can say it's probably easier said than done. But, we use statins, We use ezetimibe. We use PCSK9 inhibitors in slightly older children with HoFH. And then at age 5, even uncimab can be used, and lomidopide, I think, is at 18. And so start as early as possible. I've talked to parents with HoFH children, kids with HoFH, and kids they have to crush up the statins. At one point, there was a cherry flavored Lipitor, atorvastatin. It didn't go over well for some reason. I don't know, but so sometimes parents will put the statin in Jello, or put the statin in a little bit of pudding, or but it is sometimes challenging to have a 2-year-old swallow a pill.
Yeah.
So I think we need to also address that. Better methods of, we make every antibiotic for children is made in a liquid form, so that would be something important.
Absolutely. I know I gave my parents fits trying to take the bile acid sequestrants that we stirred up, so it can be tough, but it is so important. Okay, I think that I see that we've cleared out the Q&A. So, and given where we are at the time, I think we maybe have a couple of slides just to sort of wrap up from today. And thank you for walking through that. It's so great to hear you walk through it after, kind of seeing it all come together over the last couple of years. So we would like to thank, we've mentioned the registry and could not have done this paper and brought this important issue to the forefront without the participation of everybody in the registry. So thanks to anyone who let us use your information, who said, yes, share this, let me add my voice to this, because it made a huge difference and created this amazing asset. So we thank the participants. Also, we would not have been able to get any of the information without the PIs and the study coordinators at the various sites that we mentioned earlier that, again, are across the country. So thanks to those teams as well for helping us do that. I would love to invite everyone here to consider attending the Global Summit in October in Washington, D.C. It's an amazing event. I've been several times. It is appropriate for care providers, for those in the pharmaceutical field, for patients, for families, for caregivers. It's a really, really wonderful time to come together and see what is going on in the world of FH and HoFH. So if you haven't had a chance to go before, we would love to see you there. It's really where my relationship started with the Family Heart Foundation, was going to my first summit. So would love to see everybody there, and you can visit it at familyheart.org/summit. So that's coming up. We're excited to come back to that after COVID. And I would just again, appreciate everybody being here today. Would love to see everyone here participate either in our Facebook group or by sharing a donation so that we can keep this powerful and important work going. It's easy to donate on the website. We would appreciate your time, your money, your thoughts. Would just love to continue to grow this community even more. So thank everybody again for being here tonight. Thank you, Dr. McGowan, for walking through this and for working with me on the opportunity to be a part of this as well. I'm very excited to have shared this today, and we'll look forward to staying in touch. If anyone has questions after this, you can reach out to Family Heart. If you want to get involved, let us know, and we would love to see you. Thanks so much.